achieved controlled tipping and a single force on the center of resistance can achieve bodily movement. And for massive root movement, the single force need to apply below the center of resistance of the tooth. And this is the calculated moment to force ratio. The higher the value, the higher the difficulties of tooth movement. You may think that pure root movement is impossible for Invisalign. However, the most difficult tooth movement to move in one go with Invisalign is mesial crown and root movement, which means that the crown and the root are moved in the same direction, with the root moved in a bigger extent. Let me try to explain. This is how the plastic will deform on the attachment so that they can fulfill the desired end result on that particular aligner. And please pay attention on the attachment and plastic interface. Let's name the activation distance on the coronal part of the attachment as D1 and the cervical part as D2. The first plastic contact should be on the D1 in the tipping movement, only when the crown starts to move according to the D1 displacement, and then D2 in contact and control the root movement. For the first two tipping movement, D1 is bigger than D2. And for bodily movement, the displacement should be the same on D1 and D2. And for root movement, D2 displacement exceeds D1 in order to achieve root movement. Both of these two movements are predictable with Invisalign as D1 displacement is more than D2. The calculated equivalent force also remind us as far as the plastic can contact with the tooth or an attachment at the appropriate crown level, the desired tooth movement can be achieved. Therefore, many people said Invisalign is a tipping appliance. If we divide the plastic into three parts, the resilience of the plastic performs the best on the coronal 1/3 of the crown, which means that the plastics tend to flare at the cervical 1/3 and affecting the force application at the cervical part of the attachment. During translation movement, the plastic displacement need to be the same on both coronal and cervical part. But since it fits better at D1 than D2, and therefore the amount of root movement is always less than the planned. In other words, since we cannot provide a force at center of resistance, we need to add a force at the crown level and a couple stronger at the cervical contact in order to create a moment ratio of 8.5 to achieve this bodily translation. For mesial crown and root movement, similar concept, since we cannot apply equivalent force below the center of resistance with a liner. In order to create a moment to force ratio of 30, we need to apply a force of D1 displacement to move the crown, and at the same time, a very big moment rely on the D2 displacement at the cervical part. However, the plastic is weaker at the cervical, making this movement very, very difficult to achieve in one go. The last is pure root movement, which is having the highest moment to force ratio. And you may think that it must be unpredictable for Invisalign. However, Invisalign is actually doing quite well with pure root movement. At least I would say possible and likely. This is the explanation. Deformation at D2 is still bigger than D1. and the first contact of plastic will be on D2. Although the cervical part of the plastic is still weaker than the coronal part. However, because the displacement at D1 is so small, which means we can keep the force very low, which allow us to achieve a very big moment to force ratio of 15 to achieve the desired tooth movement. When you compare the D1 displacement in this free movement, pure root movement has the smallest D1 activation, which make it possible to create such a high moment to force ratio. In order to improve the fit at the cervical part of the plastic, as we have stressed the importance of it, this is why I normally instruct the patient at the first visit, not just biting on the chewy is not enough, but also they need to use their finger to press on the cervical part of the plastic whenever there is an attachment. And this is an important message. Sorry about the poor quality of the video. But the intention of it is to show you how you instruct the patient use their finger to press on the cervical part of the plastic to enhance the fit, because we need the force there to move the root and to enhance the fit of the aligner. We don't necessarily need an attachment every time. For example, in this case, if we want to upright forward and at the same time correct the lower midline, then we need a single force to move the crown to the left and the root to the right to upright it and at the same time correct the midline. No moment is needed. The activation point will be at the distal proximal surface of pore 1, which is readily exposed. And this is called uncontrolled tipping. Pore 1 is uprighted using the exposed proximal contact as point of application without any need of attachment. This is a very early case that I would like to use it to explain what is force and what is moment in Invisalign treatment. In this case, we plan to resolve her crowding by buccal expansion and IPR. Teeth alignment improved reasonably after 1 year of treatment. This is how it looked like at the time of refinement. And the objective of refinement at that time is just to improve the lower midline by 1 millimeter, level the curve of speed, and also tidy up the posterior open bite. In a clean check, you will see the lower incisors are moving bodily to the right to correct the 1 millimeter lower midline shift. By moving the crown to one side in this clean check is actually creating a force only on the crown level, whereas all the proximal contact are hidden and no surface is exposed for application of moment to move their root to the right. Therefore, at the end of the first refinement, all the incisors are tipped to the right, and this is also called uncontrolled tipping. Therefore, in the second refinement, I added vertical attachment on most of the lower incisors. Hopefully, try to create surface for applications of moment to upright their roots. So this is my planning. Does it work? Will it work? Unfortunately, it does not work fully. When we put vertical attachment on each individual lower incisor, the inter-attachment distance becomes very short, very small, which will reduce the resilience and flexibility of the plastic and making the plastic very rigid. Therefore, I need another refinement to upright her lower incisors root. In my third refinement, I don't use too many vertical attachment, but rather procline alternative incisor forward to expose their proximal contact so that it allowed me to apply proper moment on each individual incisors to upright their roots. And finally, we improve the root parallelism on them. If you decide to create irregularity on well-aligned incisor, you must inform and discuss with your patient beforehand, otherwise you will upset them easily and the trust will break. This is a long journey using 2 more years' time to gain root parallelism on lower incisors. I really need to thank you, my patient, to allow me to learn from my own mistake and still put trust on me. This is a 26-year-old female with a congenital missing 1 lower incisor. And her 3-7 was missing, and then the 2-7 was over-erupted. Mild crowding was present in upper and mild spacing in lower arch. The treatment plan is to redistribute space and open up the space for free-to implant replacement. OPG show roots of 3-1 and 4-1 are diverged, which means that we only need to tip 4-1 crown distal to upright it. Therefore, only a single force is needed for its uncontrolled tipping movement, and no attachment is needed. However, for 3-1, we need a more root movement than crown. And this is, as mentioned, the most difficult mesial crown and root movement that was described earlier, where we need a force at the crown level and a couple to move the roots. Therefore, we don't add any attachment on the 4-1. And the speeds of tooth movement is around 0.17 millimeter per aligner for the root and 0.12 millimeter on the crown for 3-1. Usually this is what you have, an average of the crown and the root movement, and bring that tooth and the root to the final position. And they don't take consideration which part move more to its destination. Obviously, free-to implant space was opened up, but clinical picture is not clear enough for evaluation. So I will show you how they look like at the refinement scan. Then you can see the lacking root movement on 3-1. Can you see the 3-1 root is not mesial enough? And therefore, we need a refinement to upright 3-1 roots further. Because we need an implant. So we need to show the prosthodontists that we can separate the roots and they can place the implant safely, isn't it? Evaluation on OPG. Tipping movement was planned on 4-1, and mesial crown and root movement on 3-1. Mesial root movement was further refined and an implant was successfully placed on 3-1. And this is the finishing. How about upper incisor? Align has designed more innovation and built more aligner features on them. You can have optimized root control attachment, optimized extrusion attachment, power reach, pressure area, precision bite ramp. And features available for upper lateral incisor are slightly different from the central because of its smaller size. They don't have double twin attachment for root control. You can only have 1 attachment at a time for multi-plane tooth movement or anchorage support to assist intrusion movement on centrals. The small extrusion attachment on the distal corner of the lateral is to allow distal root tip movement. The activation surface can be angulated to apply extrusion, root tip, and rotation movement. So it sounds fantastic, isn't it? Better than the control available on lower incisors. in reality, the AI is not smart enough. Let's take a look on this refinement case. I have to call for refinement at this point, as I notice crowns of 1-1 and 2-1 are tipped to the left and deviate from the original clean check. This is the first refinement clean check I received from my technician. Surprise! No attachment was added on 1-1 and 2-1 to support their root movement. They don't give me attachment. How come? The tooth movement table is telling everybody massive root tip movement was planted on all of the 4 upper incisors. The reason of not having any attachment support in this case is because I also plan palatal root torque on them, where power ridges are self-activated and they are not compatible with any attachment. So which features do you want? This is what I type and request attachment over power ridges. So always type please, us begging for attachment. So this is the second clean check came back, and which is making more sense. How about the palatal root torque? I don't have the power ridges. Can it be done without them? My answer is yes, of course, as the shape of the aligner will give you the torque. However, for root tip, we cannot improve them without the attachment support. So it is crucial to have them over power ridges. This is a case where we need to align 1-1 and 2-1 at the same time and correct its midline. And this is the first clean check that I received. So any problem with it? This is the original root position of 1-1 and 2-1 and their final position. And then you will know their type of tooth movement. You can have all this information in your tooth movement table. The illustration shows 2-1 has a difficult tooth movement. It needs distal crown and root movement. Yet they don't give you any attachment support again. Why? I need to ask the technician to add attachment on 2-1 to support the root movement. Please pay attention on the movement on 2-1. First, we keep 2-1 crown unmoved with distal root movement only. When 2-1 is uprighted, then bodily shift it to the left. So we can't do the root and the crown together. We have to move the root first. This is a 15-year-old girl with a chief complaint of upper midline off to the left-hand side. And she recalled a history of asymmetrical extraction of baby teeth in her upper arch, which caused the upper midline deviation. Molars are 1/4 cast 2 on both sides, and upper midline off to the left by 3, and the lower is on. You got a cross bite on the 2-2, and all the lower molars are lingually tilted, and posterior cross bite is present on both sides. 1-1, 2-1, and 2-2 crowns are all tipped to her left, causing the upper midline shift, which make them easier to correct with Invisalign appliance. As all of her wisdom teeth are missing and upper arch is narrow, we plan non-extraction treatment to expand and dislice her upper molars to gain space for midline correction. Mostly, we focus on the movement of central incisors, but actually, the first tooth to move during midline correction is the 1 tooth on the contralateral side. Please make sure it has appropriate attachment support and control the speed of the root movement. Usually, it will be more predictable to keep the root movement speed at around 0.1 millimeter per aligner, and does not allow the root to move faster than the crown to increase the predictability. First, we gain space from sequential distalization and expansion in upper arch. Upper midline correction was started at stage 23 when space is transferred to the front. Upper midline correction was assisted by unilateral class 2 elastic on the right, but class 2 elastic does not create any moment. It just gives a driven force. It is the engagement on the 2 points, either on attachment or proximal surface, that create that moment. It is not recommended to use too heavy class 2, as it will upset the moment to force ratio, which will cause excessive crown tipping to the right or even create canting. Luckily, we finish on time. 1121 and 22 are uprighted during midline correction, as they only required tipping movement. But the plantar tooth movement, the plantar bodily tooth movement on 11 and 12 are lacking, where their root movement didn't fully expressed. This is a difficult case for Invisalign, as there is a severe root tip discrepancy on 14 and 12. Patient's 13 had been extracted when he was a child, and therefore his upper midline was shifted to his left. The easiest way to deal with the divergent roots of 14 and 12 is definitely open up space for prosthetic replacement of his missing 13. But patient refused to have any prosthesis and can accept his upper midline shift. So we focus on the upper movement. Therefore, we plan not to fully correct his upper midline, but still need to upright his 14 to maintain a good biological width. First, determine the type of tooth movement. We need on the 14, and second, check whether it is supported with appropriate attachment. Third, if the root and the crown are moving in the same direction, and then the root need to travel more than the crown to reach its destination, then start with pure root movement first. So we keep the crown where it is at the beginning. When the root is moved more forward than the crown, then we start to move the root and the crown forward together, and overcorrection was built in. Last important message is, if extrusion movement was needed, even just a small amount of 0.8 millimeter will cause the aligner unfit with the optimized root control attachment and cause off tracking at the root tip movement. It is actually working pretty good on the mesial root tip movement on 14. But at the later stage, we found the aligner bounce and gap appear between the aligner and the tooth tip. Every single optimized attachment mostly can only serve one purpose, especially the optimized root control attachment. It cannot create any extrusion force on 14. And in reality, the plastic is extruding according to the plan, but the tooth itself is not. And the 2 points are no longer engaging properly for root tip movement. Therefore, we have to stop at this moment. During refinement, we have to change to 5 millimeter horizontal conventional attachment on 14 in order to apply further mesial root tip and extrusion movement on 14. I try to place it more towards occlusal to optimize the resilience of the plastic. Root tip on 14 was further improved. And this is how we finish the case. We compromise the occlusion on the right-hand side, but we improve the root tip on 14. So just to showing you that we are able to move the root with Invisalign. 14 was uprighted using 2 years time, but I miss out on 12, which is not fully uprighted. Let's make a comparison of the optimized and conventional attachment on root tip control. First, optimized root control attachment only serve one purpose. They only move the root okay? But however, conventional attachment, you can use it for root tip control, derotation, distalization, and also for anchorage. And for optimized attachment, sometimes it's not easy to detect the unfit unless you can see gap develop between the tooth and the aligner. So you cannot detect any early off tracking easily. And also, once you see off tracking happen with optimized attachment, you need to ask whether you need an early refinement or you have to remove those attachments and leave it for refinement. But however, for conventional attachment, even if that's lacking, I can rebond that attachment with that existing aligner. That means I accept the previous error, and right now I recapture that tooth and continue with the coming planning. And all the optimized attachment is not compatible with any elastic cutout, so they won't give you any cutout. Okay, but for the conventional attachment, they can give you cutout, but sometimes they will shift your attachment to one side, and then you need to see whether it is acceptable for you. And of course, optimized attachment have a lot of advantages. They are very forgiving. They don't have any undercut. They're small in size, not noticeable, easy to fit. Okay, and for all the conventional one, they were unforgiving. And also, if you put too many of them, you will reduce the inter-attachment distance, especially in the lower incisor. These are the early day premolar extraction cases treated with Invisalign. Different people have different explanation for it. Some say it is loss of anchorage. I lost anchorage every day with my fixed appliance, but the roots of the anchor teeth are moving forward. Not to the opposite direction. In fact, these pictures are showing an imbalance of moment to force ratio, where moment cannot be properly applied to the roots, and force at crown levels are too excessive. Particularly in the old day, we are not there to call a stop in the middle of treatment and just keep delivering the aligner. And this is the consequence. Another good example of upset of the moment to force ratio during midline correction, just mentioned early in this presentation. And another horrible consequence during incisors retraction, if we cannot deliver proper moment to control the palatal root movement, which will cause irreversible damage to the front teeth and lead to roots fenestration and loss of vitality. This is not uncommon to hear from the Invisalign group. Therefore, it's important to understand the proper moment to force ratio. Molar control is very important in orthodontic treatment. In the early days, we mostly use conventional attachment on the molar, as optimized attachments are not available yet. So let's revise what the Align engineers have designed for us in recent years. We have optimized extrusion attachment to support expansion and buccal root movement on molars, multi-plane attachment for derotation and extrusion. Optimized anchorage attachment first appeared in G6 first premolar extraction protocol, now available for both maximum and moderate anchorage reinforcement. You can only accept them as a group on all the posterior anchor teeth or replace them all with conventional attachment. We cannot just ask for optimized anchorage attachment for first molar only. Concept of molar uprighting is the same as lower incisor. All first permanent molar has certain amount of mesial tipping as they need to drift forward to close the leeway space after exfoliation of the ears. Knowing where to apply the single force to achieve the desired tooth movement is important and similar to that of the lower incisor, as mentioned very early this morning. Therefore, we can use the shortest attachment for this kind of uncontrolled tipping movement during molar distalization. You may also see many speakers don't even bother to add any attachment of molars during their distalization movement because only tipping movement is planned. However, if controlled tipping is planned during your distalization, a 4 mm vertical CRT is needed to create a surface for you to push at the cervical or create a couple for root control. For pure root movement, vertical attachment is not good enough as molar has a longer mesodistal length of about 10 mm, but relatively short crown height. If we separate the molar into meso and distal half, and we need an extrusive force at the meso and an intrusive force at the distal to create a couple to twist the root forward. The double horizontal attachment of 3 mm can also create a second pair of couple to enhance the mesial root tip movement. Remember, molar movement is mostly not just in one plane. If we need to intrude and upright the molar at the same time, this is very possible as we can easily apply an intrusion force from the aligner to the mid-fossa, passing through the center of resistance of the molar. We don't need attachment on the active sites, but we need anchorage attachment on the neighboring anchor teeth. Molar intrusion is a predictable movement with clear aligner because we can apply an intrusive force directly through the center of resistance of the molar. And that is why it is useful in treating anterior open bite cases. But of course, depends on the extent and the numbers of molars that you need to intrude, especially for intrusion of an extruded terminal molar. It is much easier than using fixed appliance, which usually need to be supported with tats to prevent buccolingual rolling and mesodistal tipping. Since it is easy, therefore, no matter patient will replace the terminal molar or not, I will be, as a courtesy, always intrude the extruded terminal molar with Invisalign appliance in my clean check. As mentioned, molar intrusion does not need an attachment on the active site, but we need to place a horizontal attachment on the anchor teeth. Overcorrection is needed to overcome the flexibility of the plastic. And this is how 2.7 look like at the refinement scan. How about if we need to extrude that molar during its uprighting? I would say it is extremely difficult to have a pure extrusion movement on molars. I would say impossible with Invisalign appliance. At the extrusion, all the extrusion movement on molars rely on engagement on gingival part of the attachment on buccal side. What is the difference between the position of these 4 horizontal attachments? Which one will you use? The first 2 attachments were not beveled, with the second one positioned more towards the gingival surface. The last 2 attachments were beveled in opposite direction. If we bevel it towards the occlusal, it can create a maximum of 1.25 millimeter profile as compared to only 1 millimeter of maximum profile in an ordinary conventional attachment. Now let's put the aligner on and feel the extrusive force from the plastic. Which one will work? If we put the attachment too close to the gingival margin, as in number 2, the plastic thickness will be reduced and the extrusive force will also be reduced. We need an undercut at the gingival surface for the application of the extrusive force. Therefore, in my opinion, it can only be possible in scenario number 1 or 4. extrusive force on the buccal surface of the molar can only extrude buccal cups down, which is called buccal root-torque. It cannot achieve pure extrusion, which is actually good because the interference always comes from the palatal cups. Remember to adjust the profile of the conventional attachment in the three-dimensional control, knowing which active surface that you want to use. A more predictable way to extrude molar with a liner is to add buttons and vertical elastic. To actively extrude the buccal cups down to close down the posterior open bite at finishing within a short period of time. Buccal vertical elastic create the vertical force also cannot make a pure extrusion on molar, only extruding the buccal side, buccal cups. Remember, do not use the box elastic design as we use in fixed appliance in Invisalign cases, as they will create rotational movement on adjacent teeth. Only 1-to-1 up and down elastic should be used to prevent the undesirable rotational movement. We always apply expansion force with Invisalign at transversal plane. They claim to be so good because the lingual surface is readily exposed and activation force can easily be applied from the lingual side. For example, in this case, where both upper and lower molars are lingually tilted, an expansion force from the lingual side will upright the molars and extrude the molars during the expansion movement. This is relative extrusion during its uprighting. However, if the molars are already upright at the beginning, an expansion force from the lingual side will actually tip all the molars crowns buccal and causing palatal cups hanging down, which will create interference and result in posterior open bite at the buccal segment, as shown in this case. Of course, the quickest ways to resolve the posterior open bite is to extrude the buccal cups down with vertical elastic. And by doing so, you are increasing the vertical dimension of the patient and should be avoided in high angle cases. I usually will cut away the whole buccal side of the plastic to enhance faster movement, which can be done in 1 month's time. However, cutting too much of the plastic, we need to watch out unwanted rotation movement, as the vertical elastic is not exactly vertical. It has a horizontal component. This is the quickest way to close down the bite, but not in all open bite cases, because open bite has different reason. So it's not just always using vertical elastic in all posterior open bite case. As a summary, we will use vertical attachment on molar for all the backward crown and root movement and mesiolingual rotation movement. For horizontal attachment, if we name the attachment surface from 1 to 4 in a clockwise manner, they all serve as different purpose. Since we can only have 5 mm maximum in length for conventional attachment, in a molar of 10 mm wide, double horizontal attachment can help to lengthen the activation point and increase the efficiency of tooth movement. Remember to check at the side view of all of your conventional attachment and bring their profile out to maximum depth to expose your preferred activation surface. If you don't do it, then you are minimizing the force application, and result is Invisalign does not work. You cannot taste the sweetness of this appliance. This is an 11-year-old boy with a chief complaint of reverse bite, anterior crossbite. In extraoral examination, he presented with concave profile with retrognathic maxilla, paranasal deficiency, and also everted lower lip. The lateral profile was taken at the forward shifted position, where you can feel the fullness of the lower lip, where lower facial height was reduced at this position. His chin is not that prominent, especially in the most retruded position. There's no history of class 3 in the family. Usually class 3 has a small upper jaw, no matter is sagittal or transversal. And this is the reason why they have severe crowding. And especially when the time comes for the canine, you found that they were blocking out. So 1-3 and 2-3 are blocked out. There's severe crowding in the upper arch. And in the lower arch, 7-5 and 8-5 are retained, and his lower 5 are congenital missing. His molar are in half unit class 2 eccentric relationship as the upper molars are drifted forward, especially on the right-hand side where 5-3 exfoliate early, causing severe crowding in upper arch with 1-3 and 2-3 blocked out. You can feel that the roots are prominent in the lower incisor, isn't it? As they have been pushed forward by the upper incisor and they were over-erupted, creating deep curve of spee in lower arch. Lateral cephalogram indicates a skeletal class 3 basal relationship. Upper and lower incisors are within the normal Chinese range. Lower facial height and mandibular plane angle were slightly reduced at the forward shifted position. Both upper canines are mesially angulated in a wrong path. 3-5 and 4-5 are congenital missing. 3-7 and 4-7 are mesially angulated. And I'm going to treat him with Invisalign. Difficult, isn't it? So which is the most difficult movement you think if using Invisalign appliance? Of course, depends on your treatment objective. I planned upper molar distalization to regain space for upper canine. Quite a massive movement in the upper right side of 4.6 millimeter of crown distalization, only 1.6 millimeter of distal crown movement on 2-6. Molars are moved in a sequential manner, not more than 2 teeth at a time. Aim at creating 7 millimeter of space for upper canines. Upper incisors are said to be unmoved, which is not logical, isn't it? Especially when upper 7s are developing. In the lower arch, we plan to mesialize lower molars forward to eaten up half of the missing 5 space and leave half for lower incisor retraction. We plan the clean check at the most retruded position. First, we keep the lower arch length, start to apply mesial root tip movement on 3-6 and 4-6 to move their root forward on day 1. Distal root tip on 3-3 and 4-3, lingual root toe on lower incisor before retraction of the crown. The only teeth with crown retraction at the beginning are 3-4 and 4-4. When the roots of most of the teeth are positioned properly, then we start to reduce the arch length and close up the space. Lower curve of spee is leveled by intrusion of lower incisor and lower first molar and extrusion of premolar. Then a vertical jump to close down the bite. Let's take a closer look on the lower teeth movement again. First, we keep the lower arch length and then start to apply mesial root tip movement on the 3-6 and 4-6 to move their root forward. So I am too slow. So we do it again. We fix the arch length, start to apply mesial root movement on 3-6 and 4-6, distal root movement on 3-3 and 4-3, lingual root toe on lower incisor before retraction of the crown. The only tooth that are moving are 3-4 and 4-4. Only when the roots are positioned properly, then we start to reduce the arch length and close up the space. This is very important. Now we close up the space. Now we're reducing the arch length, not only before the roots are fixed. This is showing you the initial and final position of 4-6. It clearly illustrates that this is a mesial crown and root tip movement, where root need to travel more than the crown to its final position with intrusion. It is advised to use double horizontal attachment to support the mesial root movement first and keep the crown static. When the root has moved forward than the crown, then we start to move it bodily forward with intrusion to its final position. This is what I'm doing in the clean check, and I hope you can see it from the clean check. In class 3 case, upper molar distalization was reinforced by the reversal vertex, where the upper incisor was locked up by the lower incisor, but just at the very beginning. Lower incisors looks retroclined with root prominent on the labial side. Therefore, it is very important to add lingual root torque on lower incisor before retraction of the crown. You can see at stage 34, lower incisors are less prominent, but lower incisors crown are also proclined, create a -6 millimeter overjet, and the pre-treatment overjet is only -3. When we start to retract lower incisor crown, it is supported by class 3 elastic, but we only use it for 2 months, and that overjet was normalized. But don't be too happy, because you can see the effect of the lower, the class 3 elastic. It extrudes the lower incisors and also retroclination of the lower incisor. We lost the torque again on lower incisor, but it is better that you regain the lower incisor angulation at the very beginning, and then you lost it again with the class 3. Therefore, it is very important that we have to normalize the lower incisor angulation if you know you need to use class 3 elastic. And class 3 elastic cannot be used too early, as we are planning distalization in the upper arch, and upper incisor are proclined forward due to the loss of anchorage during upper molars distalization, and also from the effect of the class 3. However, space still open up to allow 1-3 and 2-3 to drop in place, but just not enough, isn't it? Molars relationship has improved from class 2 to class 1, but we need to finish in class 3 molar relationship in this case, because he has missing 2 premolars in the lower arch. You can see that 3-6 and 4-6 are in an upright position in the refinement scan. And because they have been moved forward, that creates space for the mesially impacted 3-7 and 4-7 to erupt into the oral cavity. So in 1 year time, problem of the impacted upper canines and lower second molars are resolved. Posterior open bite was created due to the use of class 3 elastic, which rotate the mandible down and back by extrusion of the upper 6 and retroclination of lower incisor, creating interference on incisors. Space of missing lower second premolars was reduced by retraction of 3-4 and 4-4 at the beginning, and mesialization of the 3-6 and 4-6. So treatment evaluation, 1-3 has and 2-3 has dropped in place, even though upper molars were not distalized much, I think, and upper incisors were proclined instead. Lower first molar mesialization has been performed very well with root forward movement. Good job, aligner. Bodily retraction on 3-4 and 4-4 was poor because their extrusion movement planted in the clean check cannot be expressed Do you remember? We extrude the lower premolars to level the curve of speed during their retraction. But however, the attachment does not support the extrusion movement and causing aligner unfit on free fall and fall fall, which also ruin the root tip performance on them. Orthodontic treatment is always a mixture of successful and unsuccessful tooth movement. It provides bodily molar mesialization and also prove that it is very possible to be done with Invisalign, but with proper staging. Overjet correction is by upper incisor proclination, even though we don't plan it in a clean check. Indeed, having some upper incisor proclination is not bad. It's not a bad idea in a class 3 retrognathic maxilla case, because we don't want to do too much of irreversible planning, especially the patient is growing. And lower incisors are retracted with root closer to the lingual cortical plate, even we lost a bit of the angulation. His mandible was looking less prognathic in the retruded position and lower lip fullness was reduced. However, upper incisor were excessively proclined, making the upper lip protruded. I do hesitate to extract any of the premolars in his upper arch in class 3 moderate crowding case. Well, maybe if I do fixed appliance for him, I will extract upper 5. But if I'm doing an Invisalign, I'm not going to extract in the upper I'm not going to extract any of the upper premolar for him. Therefore, but of course, right now I'm doing refinement. I still need to tidy up the upper incisor proclination. So what am I going to plan in my refinement? I intend to extract both of his upper second molars to create space so that I can disslice his upper molars again. Besides the force we build in the plastic itself in clean check, we always use elastic to create extrinsic force on the aligner. And we need to understand fully on their effects before we decide to use them. This is a 30-year-old lady with a chief complaint of lower incisors crowding. Extraorally, she presents with a straight lateral profile and mild facial asymmetry with chin deviate to the left. Lower midline was shifted to the left by 2 mm with molar on the right, more class 3 than the left. Moderate crowding was present in lower arch and mild crowding in upper. Which lower incisor do you think from the picture is the most crowded and most forward position? It should be free one, isn't it? Then its root should be the closest to the labial cortical plate. She is a skeletal class 1 high angle case with retroclined lower incisor and lower symphysis is thin. All 8s were already removed. 1/7 was over erupted a bit as molars are more class 3 on the right. All lower molars are tipped forward. Therefore, it is not very difficult to distalize an upright lower right side molar at the same time. I suggest her to extract one lower incisor, but she said she would like to keep all of her teeth. Therefore, we plan lower molars distalization, 5 mm on the lower right side and 2 mm on the left. IPL to gain space to relieve anterior crowding and retraction of lower incisor and correct lower midline. Very greedy. I think so. Right now, when I look back on my clean check. Let's take a look on the clean check. Sequential distalization is a very important and unique planning with Invisalign. So all of my distalization planning is only sequential distalization. I don't use any other pattern. Since we plan to use class 3 elastics to support lower molar distalization, I need to add lingual rotor on all lower incisors first, except free one, which I believe at the very beginning, I do not have space to add torque on it on day one. Let's take a look again. We need to intrude 1/7 first before we can dislike 4/7. The lower molar dislocation movement is controlled tipping movement, which mostly crowns are tipped back. 3/1 was kept unmoved at the very beginning, but lingual root torque was started on the other 3 incisors on day 1. When space was transferred to 3/1, then derotation and lingual root torque was added on 3/1 at stage 27. Overjet was becoming shallowing during lower molar distalization because of the anchorage loss. Unilateral class 3 elastic was started on the right from 4/4 plastic cutout to assist lower distalization of the lower right buccal segment. When we start to use class 3 elastic on the right side, we notice gingival recession is getting worse on 3/1. Because 3/1 was kept unmoved from stage 1 to 26, and force from the class 3 elastic deformed the plastic and caused lower incisor crown retroclination, which swing its root labial. And you will feel the root prominency just by looking at the picture. And therefore, I have to stop and call for refinement to save 3/1. Lingual root torque was added on all other 3 lower incisors at the beginning, and therefore class 3 elastic has not much of effect on their root, but 3/1 is the most labially placed incisor at the beginning, and the use of class 3 elastic easily retrocline it further and create dehiscence. During refinement, we plan lingual root torque movement on 3/1 and all other lower incisor with intrusion as to eliminate the traumatic edge-to-edge bite, which may worsen the mobility on 3/1. At refinement, we add 30 degrees of lingual root torque on 3/1 on day 1. And 3/1 root was positioned 11 millimeter lingual according to the tooth movement table, which I don't think there's enough space on the lingual side of the bone, according to the set. It indicates the need to build in overcorrection, and you can feel how desperate I am. Root torque on 3/1 has improved after 1 year of refinement treatment. You may think that if I plan so massive lingual root movement, will it perforate from the lingual cortical plate? But I would say you can monitor the patient. You can monitor more regularly, and I can see that even I have planned so massive of overcorrection on it, it is just enough. And of course, root torque on 3/1 has improved after 1 year of refinement treatment. After root of 3/1 has been torqued back towards the lingual side, luckily, labial gingival regrowth. Even though it's not completely, but it's a blessing to see the improvement. After 3/1 labial gingival regrowth, class 3 elastic was started again on the right side to retract lower incisor to improve the overjet just in 2 months' time. Therefore, it is very important to know that interarch elastic create retroclination and extrusive force on lower incisor, especially on lower incisor as they are smaller than upper incisor. And we need to torque the lower incisors roots lingually before using class 3 elastic. Another thing to learn is we can start to apply lingual root torque before the incisors are fully aligned with Invisalign appliance, which is actually much better than fixed appliance, where the third order movement need to be delayed until the final stage. And this is the wire sequence of fixed appliance. 1/7 was intruded easily with clear aligner. 4/6 and 4/7 were distalized and uprighted. We have rotated the mandible down as lower incisors are extruded, creating this kind of posterior open bite. We are now in second refinement, hope to intrude the lower incisor to restore the original vertical dimension. This is the last, in the coming few slides, is the last part of the presentation. It will be very boring sitting the whole morning just to listen. So let's do some exercise together. Refresh what we had learned this morning. I shall bring you all step into this virtual world of Invisalign and reviewing some of the clean check together. Let's take a look on case 1 and focus on the tooth movement of 1, 2. First, ask yourself, what kind of tooth movement is it on 1, 2? Is it distal root tip? Let's take a look again. What kind of tooth movement? Is it having the correct attachment support? Did you see any problem with it? This is the final position. Can the attachment bring 1, 2 to its final extruded position? Can you see the amount of total extrusion by comparing the post-treatment and the pre-treatment shape of 1, 2? We are actually having some extrusion movement on 1, 2. This is the adjusted clean check where we start with distal root tip movement on 1, 2 first. Then we have to change the attachment to extrusion attachment on 1, 2 in order to extrude it into the final position. So we have to separate these two movements. And this time, let's take a look on 2, 2. And this time we use a vertical CRT, which means a vertical conventional attachment on 2, 2 to create an oblique force to fulfill the mesial buccal rotation, distal root tip, and extrusion movement on 2, 2. An oblique force gives you both vertical and horizontal force, similar idea to the optimized attachment. Remember, first we need to acknowledge the final position and check whether the tooth movement was supported with appropriate attachments. Then we have to make sure there's no interference from opposing teeth and proximal space is available for your tooth movement. And 2, 2 has improved according to the pictures. This is an open bite case. We extrude upper front teeth to close down the anterior open bite, besides molar intrusion with vertical bite jump. And please focus on 1, 1. Any problem you can spot out. 1, 1 is undergoing distal root tip movement, but without appropriate attachment support, it can never succeed. It is because the amount of extrusion movement is bigger than the root tip movement that the software decides to give you optimized extrusion attachment instead of root control attachment. And this is the artificial intelligence. Are you happy with it? No, I'm not happy with it. So this is the preferred movement, where we need to separate the distal root tip move and the extrusion tooth movement and provide different staging for them. First, we have to upright 1, 1 with optimized root control attachment, and then extrude 1, 1 and 2, 1 together to close down the anterior open bite. As you can see from the pictures, we upright 1, 1 with the optimized root control attachment. Then we change the attachment and extrude 1, 1 and 2, 1 down with the optimized extrusion attachment. Another case of upper molar dislocation. Please focus on the distalization movement of 1/7. Any problem of it? Since the movement is supported with attachment already, so any problem of it? This is a crown and root distal movement. And as mentioned in the first part of the presentation, it is a difficult movement. So what should we do to make it more predictable? This is the original angulation. As you can see, actually the root and the crown are moved together on day 1. And this is the amended clean check. It is better to start the distal root movement first. That means that we don't move the crown distal at the very beginning. Move the root first. And when the root has been positioned more distal than the crown, then we start to move the crown and the root bodily back. Another molar distalization case. When we are executing more than tooth movement on a tooth at the same time, we need to check whether they are compatible with each other. If not, then we need to separate them into different staging and also change the attachment support. You can see we are planning distalization on 1/7, but 1/7 is also buccally displaced that we need to add buccal root torque to upright it buccolingually. So we move 1/7 distal first with vertical attachment support, then change to horizontal attachment at stage 17 to support the buccal root torque movement. Another important thing to check in your clean check is the tooth movement path. The appliance is so good at expanding, and it is very routine to add the expansion force from the palatal side. However, please pay attention on tooth 3. Which part is expanding? Which part is expanding? If we draw a line to indicate the original position of tooth 3, and then you will see that it is expanding tooth 3 bodily out. In the tooth movement table, it indicates root of tooth 3 was brought towards lingual in the final position. But this is not good enough because during expansion, the shape of the aligner actually expand tooth 3 root buccally out, which will induce buccal gingival recession. And at the last few aligners, the plastic cannot bring tooth 3 root back into the lingual position shown in the tooth movement table. Of course, this clean check was not approved. Let's see the adjusted version. With the reference line again, these two clean checks are actually having the same final position. You can see that in the adjusted version, we only expand the crown of the canine out, but the pink area actually are not expanding out. And actually, when you expand the crown of the tooth 3 is the best time that to apply palatal root torque on tooth 3. Can you see right now? Do not allow the root to expand buccal. These two clean checks are having the same final position, but rather their paths are different. Where the first one bring tooth 3 root buccal during the expansion before moving it back lingual. And this is risky and unnecessary. Let's take a look on another clean check. Focus on the root movement of 3-3. Can you see it jiggle the root of 3-3 forward and then backward? Previously, I believe the final position is the most important thing to check. So I always check on my tooth movement table, whether the roots are on the lingual side, but then I realize I also need to check the tooth movement path on how they reach their final position. Why? The video, the technician swing the root forward and backward for me. Make the free dance. This is the adjusted clean check. These two clean check are also having the same final position, but free has different path to reach its destination. The reason why this jiggling root movement happened on free, I believe it is because the technician suggests a mesial root movement in clean check number 1. Then I adjust the final position of free in clean check number 2. And they don't run the program again and treat it as the additional movement on top of the first clean check and creating this weird and dangerous movement that you need to be careful of, as it brings root of free further away from your planned destination on day 1. This is the last exercise and a very common problem when resolving lower incisor crowding. So please focus on lower incisor movement. What did you see? This is very important to bring your attention to this. Lower incisor are proclined forward bodily, especially 3-2 and 4-2. Please pay attention on the pink area. This is the amended clean check where roots of lower incisor are torted lingually during their crown proclination. I can reassure you, if you accidentally approve the first clean check, you will be in a great trouble of inducing root fenestration. So in order to win the Invisalign game, you need a good patient's compliance, because this is a removable appliance. So you can only let the patient know everything, their commitment at the first consultation. Make sure they know their commitment, and you need a good patient. If the patient doesn't wear the appliance well, you lose the chance to win this game. So selection of patient is very important. And also you need good biological response. As orthodontists, we know sometimes we put wire and then the teeth take longer time in older patients. And also the bone remodeling vary among different patients. And of course, for young patients, you will definitely have better biological response than an adult patient. Finally is our responsibility to make predictable clean check. When we say so, you will be very disappointed, because even though you are very skillful with clean check setting, you only got 1/3 of the chance to win this game. But actually, don't be disappointed, okay? I would say accidentally you will find somebody who is actually know nothing about biomechanics, and then they have good case to show you. It's because everything happened just by accident. They have a very committed patient, and accidentally they have a good technician, and I think it happened in accident. So that's why this is a jackpot, because a lot of people think that they are just gambling within this line. They cannot control. But in reality, we can control from day one by selection of patient. In conclusion, we have to understand how to apply proper moment to force ratio for individual tooth movement. Extrusion movement is the most difficult, and we need to separate it. Extrinsic force is not always beneficial. Appropriate tooth movement staging is required to reinforce anchorage. Thank you very much.
Thank you so much, Dr. Charlene, for a very comprehensive and thorough presentation. I'm sure our doctors have learned a lot from it. So we now open the session for questions from our doctors. So again, for our doctors, if you do have any questions, you can type them in the Q&A box. So for our first question, hi, Dr. Wu. Thank you for your explanation. That is very easy to understand. You mentioned that we can't move root and crown together. What do you think of 2 to 4 millimeters of molar distalization? Do we have to move the crown or the root first, followed by the crown? Do you recommend any attachment? Thank you.
Yes, I'm sorry. Can I'm trying to read because wait for lower anterior inside. I noticed that. I'm sorry. Can you repeat again? I'm sorry because
No
first
problem.
question. The first
Yeah,
question
the first
is from Dr. Harry.
I think the one from Dr. Harry was already answered. The doctor already mentioned that it was answered. So he typed it in towards the beginning of the session. So the first question is the one about distalization.
Yes.
We have to move. Yeah, thank you for a very easily understandable explanation. You mentioned we can't move root and crown together. What do you think of 2 to 4 millimeters of molar distalization? Do we have to move the root first, followed by the crown? Is there any attachment needed on it?
Oh, yes, sorry. For distalization movement, it will be the same. If you need to move the roots more distal than the crown, you need to start moving the root first. As I mentioned in the last part of the exercise, then you have to move the root first. And of course, you need to support it with appropriate attachment. That will be the vertical attachment.
Okay, thank you, Dr. Wu. The next question is the one about intrusion. How much intrusion is achievable in upper molar movements?
Actually, very good is because there's no limit in the clean check for all the movement. You can distalize and can intrude up to 10 millimeter. You can do it with your clean check. But in reality, how are you going to support? And this is called anchorage. If you want to intrude more than 1 millimeter, first of all, you have to do it sequentially. That means that we cannot intrude the whole segment. Of course, and it will be very safe that your intrusion movement will be supported by mini screw. I would say 1 millimeter of molar intrusion is achievable with Invisalign. But if you need more than that, for example, 2 or 3, then you need to consider use of mini screw.
Okay, thank you, Dr. Wu. The next one is, what weight and size of elastics do you usually use for closing of open bite? I think this question was asked during the time that you were explaining about extrusion of molars.
Extrusion of molar. Oh,
yes.
Extrusion of molar, then we use a small diameter one, a 3/8 diameter elastic, 3.5 ounce only. The maximum is 3.5 ounce, no matter what size the elastic is. And according to 3M packaging, I use DAVE, D-A-V-E, 3M elastic for vertical elastic 1:1 for extrusion of the molar. So 3/8, 3.5 ounce.
Okay, thank you, Dr. Wu. The next question is on elastics again. Can you elaborate more on timing of using the elastics?
Yeah. I think I show you mainly class 3 elastic in these 2 clinical cases. I have to stress the importance of using class 3 elastic is because the advantage of it is reinforced anchorage, so you can easily see overjet correction. But then it will also have side effect because elastic on aligner is different from elastic on wire. The aligner is so flexible that the elastic will deform the aligner. So they will extrude and also retrocline the lower incisor easily by the class 3 elastic. So therefore, we don't start on day 1 is because sometimes, for example, your lower incisor is actually very retrocline and the roots are prominent. So we shouldn't do it on day 1. Okay, and also when you start the elastic, actually you will creating unfit on your aligner, which means that you will be easily have off tracking at the very beginning. So first of all, most important is you have to move the root first. Move the roots, especially the lower incisor, into the bone. And before you start to using the class 3. Yep.
Okay, thank you, Dr. Wu. Since you mentioned regarding moving the root first before the crown, a doctor is asking, how do we communicate with the technician to move the root before the crown?
Oh, I always just type. You ask them not to move the crown first, and then ask them to start moving the root. For example, in the first case, you ask them to move the root more forward than the crown. Then start to move the crown and the root together to the final position. And then they will understand. Ask them not to move the crown first.
Okay, thank you for that. The next question is regarding molar mesialization. Is Invisalign predictable in doing molar mesialization movement about 2 to 4 millimeters? How do you check the attachment design with mesialization movement?
Yeah, I think I show it in the first class 3 boy case that we have missing lower 5, and then we need to mesialize the lower 6 forward to close up half of the space. Most important, first of all, staging. That means that we need to move the root mesial first before moving the crown, because every force on the crown, squeezing force, okay, if you start to mesialize the crown forward on day 1, you are creating a force at the crown level, which will tip the root distal. So this is risky. So you have to make sure the root has been moved forward. This is the tooth movement staging, number 1. And then second is the attachment support. I prefer to use double horizontal 3 millimeter attachment in order to create an extrusive force at the mesial side of the molar and an intrusion force at the distal part. So appropriate attachment and staging. And also the last thing you have to be cautious is whether any extrusive movement is planned during your molar mesialization. Do not plan too much of extrusive, bodily extrusion. It is not compatible and it will ruin your fit. So intrusion with mesialization is okay, not extrusion with mesialization.
Okay, thank you, Dr. Shirley. I think very good tip. The next question is, when you want to procline and intrude lower incisors to level the curve of SPE without causing recession, what instruction do you give the technician and what do you look out for in the tooth movement table?
Now, lower incisors are the group of teeth that is easiest to move. Okay, so it's actually predictable to move them during leveling of the lower curve of SPE. First of all, you have to ask yourself whether you want to procline the lower incisor forward or you want just to keep the lower incisor crown position and then just torque the roots lingual. Okay, so this is your treatment planning. And also, of course, you have to check the thickness of the gum, okay, whether it can support the proclination. And also you need to check the bone, a high angle and a low angle, the symphysis width is different and it determines how much you can torque the root lingual. So my answer is, if you check everything, and then the best way is to intrude it stage-wise. That means that you can intrude 2 lower incisors first with lingual root torque, and then the lateral down, or in certain cases is 4 incisor down. But the most unpredictable is to intrude 6 front teeth down.
Okay, thank you, Dr. Charlene. The next one is, doctor wants to clarify, how can you stop movement of one tooth when you are moving other teeth at the same time, when all the teeth are connected with the aligner in reality and according to the Newton third law?
Actually, now this is the concept of your fixed appliance. As you can imagine, in bonding of your brackets, sometimes you can skip, okay? But in routine way, you bond everything and then you were expecting they move together. And I agree with fixed appliance, even if you don't bond that tooth will still move because they have transeptal fiber. But with Invisalign, you command that tooth unmove, it may not be truly unmoved, but they serve as an anchor teeth. Okay, so I would say that according to Newton's first law, action and reaction. So this is the importance of knowing sequential movement. You don't allow more than 2 teeth to move. Then that will be predictable, is because you can use the other 10 to 12 teeth as an anchor. So I'm not saying that those anchor teeth are not moving, because they can feel the action. As you can see in my case, in the upper molar distalization, in the class 3 case, we actually lost anchorage by proclining the upper incisor forward. But more important is you have to make sure the roots are still inside the bone. So what I mean is you have to check the bone thickness, and especially on the incisors region, and also check the angulation that you build in the plastic. I hope I answer your questions.
Thank you, Dr. Wu, for that explanation. The next one is regarding intrusion as well. Hello, Dr. Wu. If there is an intrusion movement on anterior and we need horizontal attachment on adjacent teeth, which is a premolar, however, the premolar is rotated and need root control attachment, which problem should we correct first? Is it the rotation or the intrusion of the anterior?
Align will recommend you using the tip by support attachment on the premolar, but if you have rotation or root tip problem, then you cannot use them, isn't it? Then you can use the far more back teeth for anchorage support to support your lower incisor intrusion. What I mean is, if your premolar need movement, then you can use conventional horizontal attachment on the 6 to support your intrusion movement. But the problem is the 6 is quite far away, isn't it, from your incisor? So that means that you need to have it create a long distance for activation. So you will be expecting loss a bit of the true activation. That means that you need to build in more of the intrusion movement on lower incisor if you want to use the molar as an anchor. But it's still very possible. You don't just need to use the premolar. You can use the molar. You can put horizontal attachment on the lower molar to support your lower incisor intrusion.
Okay, thank you, Dr. Wu. The next one is regarding uprighting teeth. Do you usually use power arms to upright 3/6 or 4/6 like molars in extraction of premolar cases? Kindly share your experience.
If you use power arm, you cannot just focus on power arm on the 6. You need to find another point of engagement at the anterior for your power arm. Now, it is possible, if you ask me, because you can direct the force down to the center of resistance, and it will be more predictable. But first of all, power arm sometimes cause irritation to your patient, and also it also relies on patient's compliance on wearing the class 1 elastic. And the elastic is sometimes irritating the mucosa around or below the mucogingival junction. So I don't routinely use it unless it is engaging to the mini screw at the back for anterior retraction of upper incisor. Then I will use power arm.
Thank you for that explanation, Dr. Wu. The next one is regarding attachments. Will it matter if we use, or I think the doctor wants to ask if there's a difference between using normal regular attachment in place of the assigned or the triggered optimized attachment?
Depends, okay. As I mentioned, the designed optimized attachment, they only serve one purpose. But sometimes they are doing multi-plane, and then you have to ask which one is the most important. And if you still want to use the optimized attachment, then you have to separate the movement. So in certain situations, people don't like to stage out is because it's slow, and then you have to change the attachment. And then you have to find an alternative, see whether any other conventional attachment can fulfill all the multiplane movement that you want and that too.
Okay. All right. Thank you, Dr. Wu. The next one is regarding the case of with 3-1, which underwent gum recession. The doctor is asking, would it be if you use class 3 elastics from a button from 4-3 instead of a cut?
I engage more distal instead of more. If you engage more mesial, the extrusive and retroclination force on incisors will be even more. Because if we just want to have a distalization force, that means that we want to assist the lower molar distalization instead of retroclination of the lower incisor. I usually prefer to engage the class 3 elastic on the premolar. However, even doing so, as you can see, my lower incisor still lost top. Okay, I still cause retroclination. So even I start the class 3, I sometimes use a short class 3, engaging from the lower premolars, not directly on the canine.
Okay, thank you. We do have a lot of questions, Dr. Wu. So the next one is, thank you, Dr. Wu, for a very detailed presentation on aligner biomechanics. Do you think that the double attachments on molars, which is without bevels, that you use work the same as the yin-yang attachments that have bevels on different sides?
About the yin-yang from somebody, okay? But the yin-yang bevel is because it is easier to fit, okay? But if you remember in my presentation, the double horizontal actually create create activation on the vertical horizontal surface, but at the side it also create point of application. But if you bevel it, then the activation point at the side is lost. So if you ask me, I don't bevel it.
Okay, thank you. The next one is regarding intrusion and distalization. The doctor is asking, what movement should we start first, and what do we what should we take note of in terms of like any precautions or anything that we need to take note of when we're performing this movement?
Distalizations are compatible. Yeah, they can be done together, no problem. Reliable.
Okay, thank you. The next question from the doctor is, excellent presentation. So would you kindly please repeat the early slide of which presented the concepts of clean check plan? Example, the final tooth position. I think the doctor is wanting to view one of the early slides.
Slide of concept of clean check plan.
Plan.
Oh, the very early one?
I think
it's just an introduction. Do you want me to show you? Let me see. Share. Are you sure you want to see? Is because actually not much particular info. It's just to let you know. I cannot share. Is it right now?
You're still sharing your screen though, doctor. We're seeing the conclusions.
Oh, yes. Sorry, because I'm seeing the picture. Okay. This one?
We're not seeing your slide yet, Dr.
Right now, can you see?
Not yet?
Not yet. Can you see now?
We're seeing the presentation. Oh, yeah.
Okay. If you don't mind, the presenter view is okay. Yep. Oh, it's okay. Can you see now?
Yes, yes, we can see the screen now.
Yeah, this is just telling you that Invisalign create a platform that you can visualize the final position. And this makes a lot of sense that you have to plan. It's not just to follow what the technician give you. Of course, this is only 2-dimensional. That means that you can only see improvement of the incisor in one plane, but more informative as you have to incorporate with your lateral set, see whether your bone is there. And actually the most difficult is to plan overcorrection. That means that if you need to retract your incisor, for example, in this case, by 5 millimeter, and actually in reality, how much it can be retract. And I will tell you that I am still not working 100% predictable. That means that I have to monitor my tooth movement. As we mentioned in the last piece of information, the biological response is different. But more important is you have to make sure you move the root in, not just the crown. Because in the clean chair, you cannot see in the picture where the root is. Only you can know where the root is from the tooth movement table. This is the most important message. And after you plan it, you have to monitor. So this is my suggestion. So what I'm going to talk is you have to make sure you know what kind of tooth movement you need to achieve the final goal, and then the attachment design and where is your anchorage is, and also your tooth movement pathway that I have explained in the last part. And also you need to avoid any interference that is possibly be there, and you need to build in overcorrection. Yeah. Hope it helped you.
Okay, so the next question is regarding posterior open bite. So the doctor is asking if there's a slight posterior open bite at the end of the treatment, apart from placing vertical elastics, as what you mentioned at the posterior molars, is there any other way around, or are there any other techniques to do?
Well, you have to know what the vertical elastic are doing. What I'm saying is I see many people pulling vertical elastic, but actually the molars are tipped, and then and also molars are not upright, and they just keep pulling the vertical elastic. And this is not the point. The point is you have to understand the reason of your posterior upper bite. And most of the posterior upper bite was created because of loss of torque of the incisor. That means that the lower incisor and the upper incisor crown were excessively retroclined. And if this is the case, then it's advised that you're not using vertical elastic because it will further your vertical dimension. You should be using your refinement, using your Invisalign appliance to detail the torque in through the lower incisor, and hopefully the bite will be closing by each other after detailing the root torque on the anterior region.
Okay, thank you for that. So for the doctors, of course, it's important to really know what is causing the posterior open bite, like what Dr. Wu mentioned. The next one is regarding optimized versus conventional attachment. Doctor is asking which optimized attachments do you think is preferable over conventional attachments for certain movements?
Optimized attachment, actually, most of them are doing quite well, except derotation attachment at the premolar. 99% it lost control. So I don't normally like to use them, the derotation attachment at premolar. The reason you have to understand the intrinsic weakness. I'm not saying the engine is not doing good. They must be doing testing before they launch everything, isn't it? But in reality is, first of all, premolars is a conical shape. So derotating it is only on buccal surface. It's only one point contact is not easy. But however, for incisor canine, you can use the mesial distal surface of the tooth to assist the derotation. And another thing more important is after the patient removes the aligner, the tooth starts to bounce back. So what I'm saying is if in Invisalign, the most difficult is you cannot control how the patient wear the aligner, how long they wear it, how precise they do it. So my recommendation is you have to let them know on day one. Okay, half of the success is depend on them. If it's not, if the patient is not doing well, and we both cannot feel the success of it. So optimize attachment, for example, to optimize root control attachment and the extrusion attachment on the incisors that are doing quite well. Yeah, and even the optimized root control attachment on the premolars, they are doing quite well. But sometimes if patient lost one attachment and they don't know it, and then your treatment also be failed. Okay, so another thing, important message, you have to ask your patient to check the existence of every single attachment. Yeah, if they lost it, then they have to call your clinic and repatch it.
Okay, thank you for that. So that's a very good tip that monitoring really is important, and you have to get the cooperation of your patients to help with the monitoring of the case in order for the patient to inform the doctor if there are attachments that dropped off. The next question is regarding expansion. So thank you, Dr. Wu. In cases where we need to expand the arch and perform sequential distalization, do you prefer to expand first, then do sequential distalization, or you do it simultaneously?
All depends what kind of expansion that you're doing. Okay. Usually for expansion, if the molars are upright, that means that you need to expand. You are creating a force from the lingual, and this will tip your root palatal, isn't it? Then that will be causing the palatal cups hanging down. If this is the case, then you need to have extrusion attachment at the side to expand and extrude at the same time in order to try to create a bodily expansion. Then if you need a horizontal attachment on the buccal, then it may not be giving you a good distalization if you are distalizing the root. But however, if you only need a tipping movement on the distalization, and maybe the horizontal surface, the number 2 surface is already can just give you a push to upright the molar. If they are mesially inclined during the distalization, then that will be good. That means that you can do the distalization and the expansion at the same time. Or maybe in certain cases, if your molar is lingually inclined, that means that only a force on the palatal is good enough to achieve the expansion. Then you don't need to have any horizontal attachment support on the buccal. Then you can use your vertical attachment to assist your distalization movement. So it all depends on how your tooth look like at the pre-treatment position.
Okay, thank you, Dr. Wu. So in the interest of time, I think we just have one more time for one more question. So for the last question, have you ever put an attachment on the lingual or palatal of the tooth to help with uprighting or to correct palatoversion? Do you think it will work?
I sometimes do put attachment on the lingual only for rotation, okay? Because I need more plastic on the mesial side to derotate certain tooth, which is not very good if I need to derotate from the buccal side of the attachment. But other than that, I won't put attachment on the lingual side because it's quite difficult to fit in, especially if you want to put buccal and lingual attachment on one tooth. It's very difficult to fit, and finally you cause unfit issue, which is actually detrimental. So I seldom put attachment on the lingual.
Okay, thank you for that, Dr. Wu. So again, thank you so much for a very comprehensive and very detailed explanation of the biomechanics of Invisalign. So let me just share my screen. So thank you also for our doctors for your question. For our doctors, we request you to kindly scan this QR code to provide us your feedback. We would greatly appreciate it. So I'll give just a few seconds for you to scan before I share with you an exciting event upcoming. So kindly provide us your valuable feedback. So we greatly appreciate it. So hope you're scanning the QR code. All right. So with that, we would also like to invite you to join us virtually for Reconnect at APAC, which is a 2-day webinar series on October 12 to 13 at 7 p.m. to 8:30 p.m. Singapore time. Here from the IDS 2021 speakers who will be joining us in this 2-day webinar series. So enjoy the opportunity to connect with them via their presentations and during the exclusive panel discussions for Asia Pacific doctors. So the first day will be on comprehensive dentistry with Dr. Camilla Morrison from UK and Dr. Marco Martignoni from Italy, with Dr. Ronnie Yap from Singapore as moderator. While the second day will be on digital workflow with speakers Dr. Michaela Senhert from Germany and Dr. Joshua Austin from the US. And this session will be moderated by Dr. Rohit Chaturvedi from Australia. So to register for this session, you just need to scan the QR code that you see on the bottom of your screen. So I'll leave this for a few seconds for you to scan if you are interested to join, but do join.
So doctors, thank you very much for joining the rerun session. We hope you picked up some additional tips from the session today. As you saw in the rerun, I would also like to remind you to join this exciting event called Reconnect at APAC for the IDS. The sessions we have are on 12th and 13th of October, as indicated by the earlier moderator as well, Dr. Meena. So on 12th of October, evening 7 to 8:30 p.m. Singapore time, we have the first session with translation. And on 13th October from 7 to 8:30 p.m. Singapore time, we have another session with simultaneous interpretation as well. So do remember to register. You can scan the QR code at the bottom right-hand side of the screen. And with that, I'd like to close this session. Thank you very much, everybody. Have a good evening and take care and stay safe. Bye.